Yeah, yes, absolutely. It's a very useful strategy. In fact, the really observant person might have noticed the photograph that I showed of the electrode removal. There was an incision right underneath my fingers. Several of the kids we've done we have used SEEG following grid. That's not to say grid is better. It's just that we did them 5 years ago with a grid, or we did them 3 years ago with a grid. And each of the kids has been like, wow, this is much easier, much better tolerated than the grid. I'm not ready to throw grids out. I think in a real world, it's like so many things that they're, each, to really use the tools in the tool shed carefully, each modality has its applications. And I still think there are probably some epilepsies that probably are appropriate for grid-based strategies, but I will tell you that SEEG is far better tolerated for kids than the grids are. A couple of things. One is that I try and avoid that area of the skull, the squamosal part of the temporal bone. I try and avoid that. If we have to come in through that area, use the shortest anchor bolt that's available, which for what we use is a 25 millimeter anchor bolt. I take that into consideration when planning, because the first little baby that I did, all my trajectories were off about an additional 6 millimeters, the same amount, and I think it had to do with the depth of the anchor bolt relative to the thin skull. I also take it into consideration in doing the planning a little bit, because you can come through adjacent areas of bone that are a little bit thicker. Fortunately, it really hasn't been a problem. If I were giving one single piece of advice to other pediatric neurosurgeons that are going to do this work in small children, it would be avoid tangential approaches through the thinnest part of the bone. If you have to come through the thin bone to get where you want with a safe trajectory, try and keep it orthogonal and use a short anchor bolt. Yeah, everything hinges from the non-invasive workup. I have no reluctance to go bilaterally, and I would submit to you that probably between a quarter and a third of our cases are bilateral. So these two cases, I tried to pick one case that was kind of straightforward and one case that was kind of not straightforward. I think it really all hinges on what the non-invasive preoperative evaluation leads you to. The biggest challenge I have right now is with regard to, and I took the Cleveland Clinic course on SEEG that was offered in May of this year, and it was an active topic of discussion, was with the modality being better tolerated and lower risk, if the capabilities are to reach safely to both sides and look well on both sides, you have to be a little careful you don't start relaxing your indications for what's really localization-related epilepsy versus more generalized epilepsy, right? Because the technique lets you look everywhere. And in fact, of our series, one of the kids we implanted, we could tell right away, and in fact, Dr. Goyle came to me, I think it was either within 24, maybe 36 hours, and she said, no, we've overreached with this. This boy has multifocal generalized epilepsy. He's seizing from all over the place. And he's our only kid in our limited series at this point who has not been offered a resection. We went to the family and we said, look, this is just not conducive. He's having too many seizures from too many different locations. There's no suggestion of localization. We just took his electrodes out, and we'll pursue strategies for generalized epilepsy, meds, VNS, potentially cannabinoid oils, and things of that nature. Maybe the diet, whatever. Yeah. Yeah, we certainly do. And, because I I've shared with my epileptologist that I don't, that I'm not reluctant to necessarily look on the other side. I have another case that I could have shown here that was, that was a classic example of why you've got to look bilaterally. The boy had cingulate epilepsy, and it overwhelmingly on non-invasive studies looked left. So our initial strategy, I think, was 8 electrodes on the left and 3 on the right. Well, sure enough, as soon as we looked, it was coming from the right. So before we took him any farther, we took him back to the operating room, like, I don't remember, 3 days later, something like that, and added another 5 electrodes to the right. So we had something like, 6 on the left and 9 or 10 on the right. So we had a lot of electrodes in that kid. So yeah, you definitely can get fooled. So yeah, but I don't go bilateral just to go bilateral. There has to be a convincing picture of what you're going to do. Yeah, I think that's an interesting question, because we really do disrupt the environment, when we put grids in. Now, that being said, kids with mild epilepsy don't go for invasive investigation. Matt Smith at St. Louis and I looked briefly at this in kids, like when do kids with grids seize? And if you don't seize with a grid within about 3 days of having your grid placed, the likelihood that you're going to seize within 17 to 20 days is single-digit %. So, so I mean, with a grid, you better seize early or you're not going to, so because that gets to be a practical question. You get a grid in a kid's head and it's 7, 8, 10 days, and the kid hasn't had a seizure and everything's getting miserable for everybody. So it's a little speculative for me to make too big of a conclusion based on as limited of a series as I have, right? A dozen cases, you can't really prove anything. But from the limited experience we have right now, the vantage point that affords me, I think the SEEG is very, very well tolerated. Grids can be managed, they can be, but they are more uncomfortable. There is more, there's just more going on. Now, whether or not it gets a better look, that's a harder call at this point in time. Our results seem very good right now, but I think to do this optimally, sort of scientifically and in terms of proper outcomes, we should wait for more numbers and more time. Incidentally, this is parenthetic, I just was talking with my fellow. We're going to try and coordinate and see if the centers that are doing kids can pull their limited numbers, because if we have a dozen and several other centers have a dozen or 10 or something like that, maybe we could pull together and get the first 50 or something like that in North America published here within the next year or so. Okay. Anybody else? All right. Well, y'all, thank you very much. I appreciate this opportunity. I'm appreciative of this, the opportunity to learn about ROSA, and I'm very interested in hearing other people's experiences as well. And thank you all for the opportunity.